My name is Benjamin Chaigne, and we're hosting a seminar on 2023 MCTD, mixed connective tissue disease, based on Dr. Kevin Chevalier's work during his PhD and his MD thesis. Kevin did his resident in our department and did a huge work on MCTD. And most of you probably know me as the other coordinator of the MCTD Reconnect group, along with Marjana, who is online. And we are very pleased to do this first webinar about MCTD. To start, the objective of this webinar to give a general overview of MCTD as a distinct entity in 2023, and to present some of the works by our groups that were published and performed this year. Basically, we'll introduce what MCTD is, then give a little bit of epidemiology, talked about the classifications of this disease, have one slide about pathophysiology, talked about how MCTD patient presented, which symptoms do they complain about. Then we'll talk about prognosis, evolution of the disease, complication, and we will then conclude. Everyone can feel free to interrupt and ask questions, or we can have a question and answer time at the end of the presentation. So as an introduction, what we can say is that Sharp syndrome, or which is now commonly known as MCTD, mixed connective tissue disease, was described more than 50 years ago by Gordon Sharp, published in the American Journal of Medicine. And basically what he said was that there is one connective tissue disease for which patients present with features of lupus, systemic sclerosis, or rheumatoid arthritis, or inflammatory myopathy, along with the specific presence of anti-U1 RNP antibodies. And he defined this disease as MCTD. Since that time, there has been a huge debate in the literature, and there is one issue that's been coming along all the time with MCTD, Sharp syndrome, is that there is this question that, is it a distinct entity? Is it a predefined connective tissue disease? And as such, it should be it should not be considered as a CTD, or is it a specific CTD? Indeed, patients with Sharp, with MCTD, do have features of lupus, SSC, or ILM, and even with that, some patients with MCTD will develop actual defined CTD, such as lupus, systemic sclerosis, RA, myopathy, and even Sjögren syndrome. To take 1 second to talk about MCTD epidemiology, there are not so many studies in the literatures. Most of the literature in the European part of the world was made in Norway. And what we have is that we have some study that evaluated the incidence and the prevalence of the disease. Most of the data came from Norway, as I said, and told us that the prevalence of the disease was 3.8 per 100,000 inhabitants, and the incidence of the disease was 2.1 per million per year per habitant. In the United States of America, in Minnesota, the incidence of MCTD was evaluated to be of 1.9 per 100,000 inhabitants per year. So it's a rare disease, which is, of course, since we are in the Reconnect group here. And then looking at the sex ratio of the patients who do develop MCTD, it's a woman predominancy of patients. On the left part of the slide, you have the representation of the number of patients and the age of patient in Gunnarsson studies. And what you can say, basically it's a middle-aged study. And in Kevin's study, what we showed and what we found is that we confirmed this data, and it's a very nice middle-aged disease. Next, we want to talk about classification, because this is part of the issue that we have with MCTD, is that there are 4 classification diagnostic criteria when you look at MCTD in the literature, at least 4. There is SHARP classification, which define patients with MCTD as long as they have anti-U1 RNP positive antibodies, no anti-SM, and clinical features of SSC, myositis, RRA, such as myositis, inflammatory myositis, pulmonary involvement, which could be pulmonary hypertension, decreased DLCO, esophageal dysmobility, Renault phenomenon, which is probably one of the main concerns actually in this disease, swallow hand, and sclerodactyly. The second classification is Kazukawa classification, which also state, and it's the common thing in all classification, the presence of anti-U1 RNP antibodies, along with, here again, clinical features of SLE, SSC, and myositis, as you can see on this slide with SLE features, SSC features, PM features. Third classification is the Alarcon-Segovia and Villarreal, which we will call Alarcon-Segovia classification, which classify patients with MCTD if they have anti-RNP antibodies with, here again, clinical symptoms such as edema of the hands, synovitis, myositis, Renault phenomenon, atherosclerosis. And last but not least, the CAN classification. Here again, presence of RNP antibodies, positive, with clinical features of systemic sclerosis, including Renault phenomenon, as well as synovitis, myositis, and scleroderma. So what you can see here is that MCTD is defined by the presence of antibody RNP, and that there are some common symptoms in all classification. And this is where I hand to Kevin, who will introduce his MD thesis, and I hand it to Kevin now.
Thank you, Benjamin. So one of the main questions about this classification is their relevance. Next slide, please. To answer this question, and of course, another ones, we have conducted an international retrospective multicentric national French study. Patients who fulfilled at least one of the 4 classification criteria for MCTD have been included. And patients who fulfilled at least one other cognitive tissue disease classification, such as lupus, systemic sclerosis, Sjogren's syndrome, have been excluded. Next slide, please. So we have collected 1,772 patients in 13 French medical departments. Among them, 154 have been excluded because of lack of data or duplicates. So 1,618 patients have been screened. 1,288 patients have been excluded because at diagnosis, they have the criteria for lupus systemic, Sjogren's syndrome, idiopathic inflammatory myopathies, rheumatoid arthritis, or an overlap connective tissue disease, an undifferentiated connective tissue disease, or they had an other disease. So finally, in our study, 330 patients have been included. Next slide, please. Among these, 71 patients fulfill the 4 classification criteria for MCTD, and 210 fulfill at the same time SHARP and Kazukawa criteria. Next slide. Interestingly, the vast majority of our patients fulfill SHARP and or Kazukawa criteria. Moreover, only 1/4 of our patients fulfill Alarcon-Segovia or CAN criteria. And no patient fulfilled only Alarcon-Segovia or CAN criteria without fulfilling at least SHARP and or Kazukawa criteria. Next slide. 4 cohort study about MCTD have studied the percentage of patients who fulfill the 4 MCTD classification criteria. As you can see in the table, the number and the percentage of patients who fulfill this criteria is very heterogeneous in the different studies. Moreover, like in your study, in the Gunnarsson and Hall study performed in Norway, only 1% of their patients fulfill only Alarcon-Segovia criteria without fulfilling a CAN or SHARP criteria. Moreover, 3 studies have studied the diagnosis performance of these criteria, and they conclude that Kazukawa and SHARP criteria have the highest sensibility when Kazukawa criteria have the highest specificity. Next slide, please. So, taken together, these data suggest that Alarcon-Segovia and CAN criteria are redundant with SHARP and Kazukawa criteria. And so, Kazukawa and or SHARP criteria seems to be sufficient to classify and diagnose patients with MCTD in clinical practice. Nevertheless, these criteria are very old, and so new consensual criteria are needed. Next slide.
So to move on from classification, where you basically saw the among and huge work Kevin did in this MD thesis, working on 330 patients with MCTD, which is amazing. We will now move to pathophysiology of the disease, just for one slide, saying that to date, there is not so many sufficient data to explain the disease of the pathophysiology. And what we can find in the literature is that there is a genetic predisposition based on HLA, and with some HLA genes that are protective, where some HLA genes are associated with the disease. What we can say about MCTD is that it's a B-cell disease with the secretion by plasmocyte of anti-RNP antibodies. And just to give a look of what the RNP complex, what the antibodies are targeting, you have on the left part of the slide a representation from Hoff in autoimmunity review in 2005 of the RNP complex targeted, which is the combination of 3 snRNP, U1A, U170K, and U1C on a gene, along with SM proteins as well, which explain why some patients with anti-RNP antibodies also have anti-SM proteins, which can be found in lupus, as most of you know. What we can say about the disease, that as in many autoimmune diseases, you do have autoantigen modification as an hypothesis, innate immune activation with TLR activation, B lymphocyte as stated, and T lymphocyte activation. On the right part of the slide, you have a representation of how tissue damage are made in MCTDs in a paper by Hoffman et al. In 2008 that you can easily find. If we move to disease presentation, just before ending to Kevin, I would just say that in previous paper and in major paper, which is the paper by Gunnarsson, what was known about MCTD is that it's a disease where, of course, there are anti-RNP positive antibodies, but that the main symptom is Raynaud phenomenon. And for people who are not clinicians listening to us, this is what Raynaud phenomenon looks like. You can have puffy hands or sclerodactyly. On this picture on the left side, you do have a picture of puffy hand syndromes. And puffy hands is, in Gunnarsson study, the second major symptoms, major complaint by patient. The third one is arthritis, present in 79% of the patients. And then you move along to esophageal dysmobility, which sounds very much like systemic sclerosis. Then to dyspnea, along with ILD, which is represented, for which you have an example on CT scans just over here. And then you do have sclerodactyly, dyspnea, muscle weakness as other symptoms. What you can see is that some patients do have pruritus and pericarditis, but it's about 10% of the patient. And now I hand it to Kevin, that I will show you what he found as disease presentation in MCTD.
So the second main topic of this presentation is about the MCTD presentation in 2023. Next slide, please. In our study, the vast majority of our patients were women. At MCTD diagnosis, the main clinical symptoms were Raynaud's phenomenon in 91% of our patients, arthralgia and many arthritis in 83% of our patients, puffy fingers in almost half of our cohort, and myalgia in about 1/3 of the patients. Of course, all of our patients had anti-U1 RNP antibodies. At MCTD diagnosis, 155 patients had a naifold capillaroscopy. Among them, almost half had an abnormal one defined by the presence of microhemorrhages and/or avascular area and/or giant capillaries. 38 patients, so 11.5% of our patients, had an ILD at MCTD diagnosis, and 10 patients had pulmonary hypertension.
Move along to disease prognosis. What we find in the literature is that there is no clear-cut evolution for MCTD patient when you look at every studies that have been performed. What we know is that between 0 or 90% of the patient, depending on the study, will evolve to a defined CTD. What we know is that the main defined CTDs that patient evolve towards to are systemic sclerosis, SLE, and possibly Sjogren's or rheumatoid arthritis. But as you can see, it's not very clear in the literature, and it's between 0 and 55% for SSC, 0 and 25% for SLE, and overall between 0 and 90% of the studies. So looking again at prognosis, the question is it a severe disease? And do patients can have remission of the disease, which always depends on the way you define remission. What we know from the literature is that death is rarely happening in the disease, but may occur. And in the paper by Gunnarsson, it was about 13% of the patients who die, and major complication of the disease were pulmonary hypertension, ILD, cancer, and once renal crisis, which made us think that this patient had systemic sclerosis. Overall, what we can say in the literature is that the sharp mortality is between 3 and 10% within 10 years, and that half of the patient can be in remission or active within this duration. But that was another question we wanted to raise in Kevin's work.
So the third topic of this presentation is about the MCTD prognosis in 2023. Next slide, please. In our study, among the 330 patients, only 85 evolved toward a differentiated connective tissue disease. Among these patients, 52 fulfill the systemic sclerosis classification criteria, 35 the lupus criteria, 15 the Sjogren's syndrome criteria, only 5 the rheumatoid arthritis criteria, and 3 the idiopathic inflammatory myopathies criteria. So overall, 65 of our patients fulfill one CTD classification criteria, and 20 had an overlap connective tissue disease syndrome. Next slide. So we have studied the evolution to the differentiated connective tissue disease over time. As you can see, the median time between MCTD diagnosis and evolution to a differentiated connective tissue disease is 5 years. In the left side of the slide, you have the evolution over time for each connective tissue disease. As you can see, for the 3 major ones, systemic sclerosis in yellow-brown, lupus in green, and Sjogren in blue, the time between MCTD diagnosis and evolution to this connective tissue disease is quite the same. In the right side of the slide, we have studied the evolution to one connective tissue disease in green, or to an overlap connective tissue disease syndrome in blue. As you can see, the curves are quite the same. Next slide, please. Next, we have studied the prognosis of this patient. In our study, 45% of our patients were in remission at the last follow-up, after a median follow-up of 8 years. In our study, like in Gunnarsson and colleagues' study, we have defined the remission by the combination of the lupus remission criteria according to the Doris definition and an ELAR activity index below 2.5. Moreover, in our study, 18 patients died during the follow-up. The causes of death were related to pulmonary hypertension in 1/3 of the patients, ILD in 2 patients, and cancer in 3, infection with septic shock in 5 patients, and cardiovascular disease in 2. Next slide, please. So, MCTD is a distinct entity defining an homogeneous group of patients with only a quarter will evolve toward a defined connective tissue disease. These patients had a low mortality, and nearly half of them were in remission after at the last follow-up. Next slide, please. But two major complications impact the patient survival. It is the presence of interstitial lung disease and pulmonary hypertension or pulmonary arterial hypertension. Next slide, please. Interstitial lung disease is very frequent in MCTD. In the literature, about 1/4 to half of the patients with MCTD had an interstitial lung disease. In the Norway cohort conducted by Gunnarsson and colleagues, the half of the 126 patients had an ALD. In this patient, 35% had fibrosis in chest CT scan, and the ILD was severe in 19% of the patients. In the literature, the radiological pattern is mostly a non-specific interstitial pneumonia and rarely unusual interstitial pneumonia. Some signs are associated with the presence of interstitial lung disease in MCTD patients. It was the presence of a dysphagia, an esophagus dysmotility, the presence of a Raynaud's phenomenon, anti-SSA antibody or anti-SM antibody, and rheumatoid factors. The evolutivity of ILD in MCTD patients is quite low, but as you know, it increases the mortality of this patient when the ILD is progressive. Next slide, please.
The second major complication for MCTD patient is pulmonary arterial hypertension, PAH. And as probably most of you know, connective tissue disease is the second cause of PAH. And among CTD, MCTD is known to be the third one to cause PAH. The prevalence of PAH associated to MCTDs goes from 3.4 in Europe to 43% in Japan. It's associated in MCTD with a high mortality, 25% in Norway after 6 years, 41% in Hungary after 15 years. It's basically with ILD, the two major complications and probably the main causes of death in the disease. Still, we think and we thought that there were limited data looking at pH in MCTD and especially on pH defined with right heart catheterization. And therefore, and this is the first thing we wanted to update you within this seminar, we did a work on MCTD pH. It's a work we performed within the internal department of internal medicine with my boss, Luc Mouthon, and in collaboration with the amazing pulmonary hypertension French referral center which is a collaboration we did with Marc Imbert, Olivier Sidbon, and Athénaïs Boucli, and every people in France who participate in this registry of French pulmonary hypertension. And so what we did is that we found 36 patients who did have MCTD and PH defined by RHC, and we compared them to MCTD controls, basically patients with MCTD without PH. And first thing we noted is that patients with MCTD and PH had more pericarditis, less polyarthritis, and more ILD patients. And when we did statistics to look for risk factor associated to PH within MCTD, what we found was that pericarditis predicts success perfectly. Polyarthritis was negatively associated to PH. Thrombocytopenia was risk predictor perfect one. ILD was associated to PH and also anti-SM antibodies. So within this, the first thing we found in this work is that we can have some risk factor for PH for some patients with MCTD. The second question we raised in this study was, is MCTD PH different from other CTD PH, and basically SLE PH or SSC patients? So we compared 19 of our patients, the one for which we have diagnosed of PH after 2006, with age and sex and disease diagnosed match control with SLE PH and SSC PH. And when we compared the three groups, basically we didn't find any major difference. So what we can say from this part of the work was that MCTD PH resembled to SLE PH and SSC PH in terms of presentation. And the other thing was that a quarter of our patients enter MCTD disease because of PH. Looking at patient survival, we confirmed what was known in the literature is that patients with MCTD, when they do have PH, they have a worse survival than patients without PH when they have MCTD. So PH is clearly one of the complications we should look for within our patients. Then when we try to differentiate MCTD PH from SLE PH from SSC PH in terms of survival, we didn't find any difference. Then we look for risk factor of death within MCTD PH patients. And we find that tobacco exposure was clearly associated with a worse survival in MCTD PH patients. So therefore, we clearly, and it seems obvious that patients with MCTD should quit smoking, but I'm sure this is quite obvious for anyone around here. And then when we look, because many of our patients did have ILD, we look for a difference between the survival of patients with ILD PH and those who didn't have ILD but still have PH, and we didn't find any difference in terms of survival in this work. So to conclude on this work, we confirmed that PH is a severe complication of MCTD. We showed that MCTD resembled to other CTD PH. We find that MCTD patient with ILD, pericarditis, thrombocytopenia, and anti-SM should be carefully screened for PH or PH. We stated, and I didn't tell you about that MCTD PH survival rates is at 1, 5, and 10 years, 83%, 67%, and 56% respectively. And finally, that tobacco is associated with worse prognosis in MCTD PH.
To conclude this seminar, MCTD is a distinct entity which defines an homogeneous group of patients. So in a patient with CTD symptoms and anti-U1 RNP antibodies, you should think about sharp disease. The Kazukawa and sharp criteria should be used in clinical practice to classify a diagnosed patient until new criteria are defined. Only 1/4 of MCTD patients will evolve toward a defined connective tissue disease. The main clinical symptoms at disease presentation were Raynaud's phenomenon, arthralgia, puffy fingers, and anti-U1 RNP antibodies. Overall, MCTD seems to have a very good prognosis, but two major complications impact the patient survival: the presence of pulmonary hypertension and interstitial lung disease. So patients with MCTD should be screened for pulmonary hypertension and ILD at diagnosis and during the follow-up.
And last but not least, we are thinking of doing a European registry within the Reconnect MCT disease group, and you will soon be contacted by Kevin and I to participate to a European registry for this amazing disease. And with that, we thank you for your attention. And if you do have any questions, we will be very happy to discuss this webinar and topics with you all. Thank you very much.
Thank you very much.